So we'll be hearing first from Dr. Gottlieb. And
good morning, all.
There, wonderful. Good morning.
Yeah, it is early here, but I'm totally delighted to be able to join the group. If I just stop talking, somebody scream, and I'm sure I'll wake right up. So, Mark, thanks for the introduction. I am a family physician researcher at UCSF, and I'm the director of the Social Interventions Research and Evaluation Network, or SIREN, which, much like it sounds, is a research group focused on the intersection of social and medical care delivery. And I really am grateful to Mark and Sami and Alina and the other roundtable staff and organizers for not only including me, but for accommodating the technology to participate from afar. My plan today is really just to review some of the ways healthcare systems are improving health for individual patients and for communities by addressing social conditions. And just one point to briefly note before I kick things off, as Sane mentioned, I'm going to be using language adopted by the recent National Academies Committee on Integrating Social Care into Healthcare Delivery. And we really would love people who are interested to join that public release of the committee's report next Wednesday. So please do look in your packet to find the registration information. Okay. So let me just start by acknowledging something everyone in this room and watching via webinar already knows. Social determinants are in vogue in the U.S. healthcare sector. They become a central focus not only of healthcare-based reports and papers and conferences, but also of many clinical innovations and both public and private healthcare payment models. That makes it a very exciting time to be in this field, but it also means so much is happening that sometimes it can feel a little overwhelming. And I often start with this slide because it does sometimes feel like I could be crushed by the massive social determinant snowball heading down a very steep hill. And in fact, if you believe all the webinars, reports, and papers that we get every week on social determinants, assessing and addressing social risk within the healthcare delivery system is going to fix everything that ails the U.S. healthcare system. And it is the solution to achieving population health and health equity. I like to say that because we're at the beginning of what in technology startup language is called an innovation hype cycle. The first phase of that cycle typically involves a peak of inflated expectations where early publicity produces many success stories. Unfortunately, that peak is often followed by a trough of disillusionment where early innovations don't consistently deliver. And our job is to gradually move up the slope of enlightenment to the plateau of productivity to find effective and scalable interventions. With that background in mind, I'll share the 5 different healthcare sector approaches that we articulated in the NASM committee to providing social care or improving social conditions with that end goal in mind of reaching the plateau of productivity. So the first step towards improving social conditions is by increasing awareness of risk factors. So increasingly, healthcare delivery systems are investing in ways to better understand patient and population level social risk. At the patient level, we've seen that manifest in the adoption of an ever-widening range of standardized social risk screening tools. So 3 examples of common tools are in this table, including a set of measures proposed by an earlier National Academies Committee. The second column here highlights work from the National Association of Community Health Centers and their close partners around the PREPARE tools. And the third column shows some of the social risk domains, or actually all of the social risk domains included in a tool developed under the Center for Medicare and Medicaid Innovation's Accountable Health Communities demonstration project. So you can see in the slide that there's actually relatively little consensus around what social risk factors to screen for in clinical settings. When there is consensus, people are using different measures, are frequently using different measures. So moreover, there's little consensus on whether it is appropriate or feasible to conduct social risk screening at the patient level at all. And in fact, as one alternative, some health systems are exploring ways to increase awareness of social conditions and social risk factors, not by asking patients directly about their social risks when they arrive in clinics or emergency rooms, but instead by collecting community-level social risk information, for instance, based on patient addresses or zip codes. A number of different technology programs have sprung up in this space that can facilitate the efforts to display community-level data. So Health Landscape, for instance, now offers ways for health systems to map their own patient data to see where their patients live and the social resources available in those communities. So you start to see how awareness strategies span the spectrum from being very patient or healthcare delivery focused to more community or neighborhood focused. And that same spectrum is relevant to categorizing the range of things healthcare systems are actually doing to address social conditions once they are aware of them. So those activities that healthcare systems undertake to address social conditions for patients generally fall into two categories. So on the left side of our spectrum, activities that they're undertaking for patients or in the healthcare delivery system. The first of those two categories on this side of the spectrum involves activities where providers adjust medical care or adjust treatment decisions based on information about social risk. And the second involves activities where healthcare systems intervene more directly to assist patients in addressing the social risk itself, whether by providing social services on site or bridging to services off site. And I'm going to take a couple minutes to just delve into each of these two categories a little. So first, what do I mean by adjusting care? So we don't talk about this a lot, but this is work that as providers, as a family physician, for instance, I do every day in the safety net, though not always well or systematically. We accommodate social factors that could interfere with medical treatment. We try to improve access to care for patients who don't have great access. For instance, we send out mobile vans, we offer evening and weekend clinics, we provide interpreters to patients who don't speak the same language. We also use social data to inform diagnostics. As an example, the mini mental status is adjusted for literacy level. And finally, we adjust our treatment plans based on social risk. So for instance, a new American College of Obstetrics and Gynecology guidelines recommends treating all low-income pregnant women with aspirin to prevent preeclampsia. And recommendations for treating hypertension in homeless populations include avoiding the use of diuretics, since lack of restroom access can contribute to non-adherence. A major obstacle to adjustment, or what I've been referring to as social risk-informed care, is that in the healthcare system, we don't actually think about those things for every patient every day. We haven't tied a ribbon around those interventions or protocolized them, studied them, learned what works best and for whom. In general, we do social risk-informed care inconsistently. So we now need better evidence to know how to use social risk data to improve conventional care in our own wheelhouse of medicine, and then we need to have the right social data available to providers and effective interventions built into our electronic health system or health records. There is some interesting work coming out around social risk-informed diabetes care from folks like Tiffany Vano in Michigan, Danielle Hessler at UCSF, and Rachel Gould at Kaiser. This table comes from a recent JAMA paper Vano's team published, where they explored the different ways in which providers caring for patients with diabetes endorse changing care based on information about patients' social risk. So in their study, the patients reported changing target blood sugar goals, doing more cost-sensitive prescribing, and making other significant changes to guideline concordant care based on available information about social risk. And I think it can be a useful model for using these data to inform chronic disease management in other cases. More common in the news and health services research, though, is this cluster of activities related to what we in the National Academies report refer to as assistance or social risk targeted care. And this is where we actually use, or healthcare system resources are actually targeted in some way to improve patients' social context. So instead of using non-refrigerated medication, we might help the patient get a refrigerator. In other examples, we help to connect patients with food programs, like they're doing for every hospitalized patient at ProMedica. And that I'm not sure, but maybe Seth will talk about later today. We may help patients obtain a living wage job, like they're doing at Roots Community Health Center in Oakland. We pay for housing support specialists, like they're doing under the California 1115 waivers. Again, all of these interventions are sometimes part of care, but are not usually systematically built into practice. So let's return to that framework. So adjustment and assistance are both strategies focused on patients and healthcare delivery. That the National Academies Committee also looked at ways that healthcare systems can impact social conditions in ways much more focused on community-level activities. And like Sani mentioned in her opening, the committee talked a lot about the appropriate level of humility and partnership that's needed for these activities. So these include efforts to improve the availability of social resources for everyone, not just patients. And these strategies can involve better aligning healthcare actions with community priorities and advocating for policy changes that will change the resource and equity landscape more broadly. So what do these alignment, investment, and advocacy activities look like in practice? I'll just highlight a few examples, but I suspect many of you are already perhaps even more familiar with these than some of the ones I mentioned earlier on the healthcare side of the spectrum. So one that I'll highlight is the concept of anchor institutions, which the Democracy Collaborative has helped to scale nationally. This is the idea that hospitals and health systems might better align their own institutional practices, for instance, around hiring, procurement, and waste, with the needs of their surrounding communities. In another example, I can highlight the alignment track of the CMMI Accountable Health Communities demonstration, where 24 health systems around the U.S. are not only assisting patients to connect with social services on the healthcare delivery side, but convening intersectoral advisory committees designed to fill community social service gaps. And of course, there are many other examples in which healthcare systems are investing in or advocating for new community resources, including new housing or increases in public benefits. So I'll just walk through an example here around food security in which these different healthcare sector approaches could all be engaged simultaneously. They're certainly not mutually exclusive. So, for instance, providers could suggest adjusting insulin doses to avoid hypoglycemia in a patient when their food benefits get low. And Hilary Saladin and Seth Berkowitz have written about that as a phenomenon. If we look at the assistance approach, community health workers could provide supports for meal programs or connect patients with food benefit programs. On the alignment side, the hospital might support local food producers by sourcing hospital food from local farms or hosting farmers markets. And finally, the hospital could advocate to bolster or at this moment in time, at least continue food benefits for some low-income populations. I hope that this helps to organize the wide variety of healthcare activities emerging in this rapidly evolving space, and ideally help frame the discussions you'll have in the room throughout the day. But with my final few minutes, I want to underscore that none of this work is easy. In fact, the coordinating committee titled the workshop Tensions and Promise on the Path Upstream, which I really suspect was their shorthand for saying, even if we believe that integration is important, that upstream and downstream approaches are critical, we also know that there are big obstacles and many potential unintended consequences, especially when asking the healthcare sector to increase its engagement around social conditions at the community level. So with my last slide, I thought I might name a few of the big thorny tensions. I wasn't sure if it was thorny or hairy, but either way, big tensions or unintended consequences in this space. So it's been helpful for me to think about the conceivable unintended consequences by stakeholder. So let's just think about patients. Is it possible that asking about social risk factors could turn patients off, potentially worsening their relationships with providers, especially if they feel like they share something and that's not heard or not addressed? Could it therefore exacerbate big inequities in their access of healthcare services or their adherence with treatment? And for providers, could having social risk data available at the point of care increase opportunities for discrimination, exacerbating treatment bias in medicine as opposed to decreasing health inequities? Could it overwhelm busy clinicians and worsen burnout? And then for the social sector, could the healthcare sector's sudden enthusiasm around social determinants actually end up exacerbating our underfunding crisis in the third sector? Maybe. And these are just a few of those big questions, those big tensions. So this is where I get to say that I think our obligation as academics is to work closely with patients, providers, community members, public health and social service representatives to surface the potential unintended consequences. And then we have to invest in the necessary effectiveness and implementation research that will enable us to better understand how healthcare activities in this space really affect all those stakeholders, including those of different ages, races, religions, gender, ability status. We have started to do that a little bit at Siren. We have some early evidence showing that some of these potential consequences are actually unlikely. The ones that these potential consequences that we're fearful of are unlikely. So for instance, patients seem to really appreciate being asked about social risk in clinical settings, but not all patients. And they don't expect providers to resolve all their social risks, but they nonetheless want to talk about them in clinics. And providers working in clinics that offer more social services are actually less likely to be burned out, not more. But we have to keep asking these questions and learning from the many organizations not only committed to doing more in this space, but doing it with a focus on equity. Okay, so that's my very high-level overview of what I see happening in this quickly evolving field. I did want to share information about our Social Interventions Research and Evaluation Network, SIREN, which I do hope can serve as an ongoing resource for those of you who are interested in learning more or doing more in this area. We are housed at UCSF, funded by Kaiser Permanente and the Robert Wood Johnson Foundation. And our goal really is just to generate more high-quality evidence in this field and put it in the hands of those of you who can use it. So I am really looking forward to hearing Ben talk more about North Carolina and to the ensuing discussion. Thank you so much.